So this is forward, I think. Thank you very much, ladies and gentlemen, for inviting me here, and for the, especially for the organizers. I mean, first, my role is here to talk about the Swedish physical activity on prescription model, and I would also like to give an overview if we are active. And I'm not so sure we are that as much active as you said. So let's start. And then we will have a nice discussion with a panel discussion after my talk. Let's see if this is the next one. No, that was the wrong one. Which one is forward then? This one. Yeah. So, lifestyle contributes to a majority of our health. And this is very important because if it's over 50% of our total health comes from lifestyle, then we only put like 1 or 2% into that lifestyle medicine or prevention in healthcare. And this is possibly our biggest future challenge, to change that percentage. Because we know physical activity is good for almost every organ in the body, and we don't have to go through this here, but it's cardiovascular, mental, and bone health, and so on. So are we then active? And as the moderator said here, or the chairman said, the Swedish authorities claim that about 2 out of 3 of our citizens are sufficiently active according to the national guidelines, which are the same guidelines as we have in almost every other country. That means 150 minutes of medium intensity activity in a week, 30 minutes 5 times a week. But I put a question mark there because this is based on what people report. So this is self-assessment, and you can do other measurements and more objective measurements to look at that. And we did that in the very large SCAPIS trial, which is a trial of 30,000 people, middle-aged people in Sweden, just completed from 6 universities. That means that we have done testing, numerous testing for 2 days on these 30,000 people, unselected from the population, and including physical activity measurements and CT angio and a lot of other things. But what we can see from the first 1,000 in the pilot was that about, you can see here, this is what we can see in the black. This is the waking hours, and you can see the men on the left, the women on the right. And of the waking hours, about between 9 and 10 hours are dark gray. That's sitting. So 9 to 10 hours out of 16 is sitting, and then you have low intensity activity, which is the lighter gray area, and then a little tiny bit, which is medium and high intensity put together. And that actually almost reaches 30 minutes a day. But if you have the prerequisite to say 5 days a week, you have to reach this. Only 1 out of 3 in this population between 50 to 65 reaches the national recommendations. And then you can say, okay, this is relatively older people, 50 to 65, but in youngsters, we have seen in other studies that it's even worse. So they do more exercise, but they also sit more. So they can sit up to 75% of the waking hours. Even worse in the weekends, actually, over 80%. So this is the situation. So we're not that active as we may have thought. And also, even worse, we can't predict it so well. So we did, because we asked people how much they were active, and we also did measurements with accelerometer. So we published this study saying that, can we predict how much we sit for a day? And we are lousy at that, I can say. I mean, looking here, from this slide here, you can see that on the up, this is the y-axis, how many minutes do you sit per day, and the x-axis is what you really sit, measuring by accelerometer. And you can see it's very much underappreciated, the time of sitting. So if somebody says that I sit 6 hours, I sat 6 hours yesterday, it's probably 9 hours. So 3 hours underevaluation, the mean underevaluation per day, 3 hours. And unfortunately, it's the opposite with exercise. Then we overestimate. So if somebody says, how much medium or high intensity activity do you do a day? And if people say 60 minutes, it's probably 30. So this is, at least in our country, it's an over-exaggeration, and we think it's the result of what we call social desirability. It's a question we really want to say yes to if we do exercise. And the future looks even worse. So this is the predicted outcome in the coming 20, 30 years, that every form of activity will go down even more, and the only line which is going up there, it's the line for sitting time. So if this is a problem now with physical inactivity, it's going to be even worse in the future. Which is, I mean, look, this is really serious, because now this study is accepted now, going to be published very soon. It's presented at Europe Prevent this spring. This is showing if you can increase your activity after myocardial infarction. We did a study of all the myocardial infarctions in Sweden during a period. This was like 35,000 myocardial infarctions, and we can see activity 6 weeks after the infarction and 1 year after the infarction. If you increase your activity or keep your high activity, then you can see the green line there. The survival compared to the red line, which is inactive people, is double. And this is up to 3,000–4,000 days. That means up to 10 years. So the survival is double if you increase activity from whatever level compared to being inactive or decreasing your activity. So it does make a change, does make a difference if you change your activity even after myocardial infarction. And I think these figures we need to emphasize, to put physical activity after myocardial infarction, for instance. This is independent of cardiac rehab, by the way, independent of cardiac rehab. So we all need, we think physical activity is good, but we have a challenge. How do we implement this? Can we have methods to increase the activity? And we have lots of barriers. We tend to blame the patient. Patients have lack of motivation, difficulty of changing lifestyle, and so on. And yes, there are differences in knowledge, education, socioeconomics, and so on. So there is a difference in the patient. It's very difficult to change lifestyle. But I would also like to stress all the barriers we have in the healthcare system, all the way from the management to the individual doctor. The motivation of the doctor is very low. If there is any other treatment that could halve the deaths after myocardial infarction, I promise you it would take 1 week to implement it if there was a new medication. But this takes, you know, we can really make this difficult and find reasons not to do this. So it's very, very strange. But lack of structural support is important, lack of time, lack of reimbursement, lack of education. The students at medical school, has been shown in an American study, are more positive to lifestyle change when they start med school than when they finish. So it's the professors like us who stop them from being positive to lifestyle and instead turn them on to medications. So this is the university's fault also. And also, if you are active yourself, you're much more inclined to help the patients. This is very important as well. And the attitudes, you can see here, going from, this is the attitudes in a thoracic clinic in Stockholm, the Sahlgrenska hospital, that people tend, you see the people working at the cardiology units, they think it's very important in general, but to misspell there, very important in general to be active and help the patients with lifestyle. It's very important in their own practice, but they don't always ask, and they even less give counsel. So how is that? We think it's important, but we don't do it. And this is very important, very interesting. We must have a system that can increase the activity. I mean, we have tried general advice for 100 years. It's not so efficient. People are less active than ever. So we cannot just say to people, be a little more active, you know, tell them when they leave the room, so to speak, because they have a misconception. They think they're activer than they are. So this is not a very good idea. You have to do more. You have to give them advice with additional support, pedometers, diaries, follow-up. That's a little better uptake. You can do exercise referral schemes, which is more complex. It's been tried in Denmark and the UK. You send them away to physiotherapists to train for a couple of months, and then they come back. The problem with that is it hasn't been shown in systematic reviews to work, probably because you go back to your own activity after. And you also decrease your activity during such referral schemes, as also been shown for cardiac rehab, by the way. So, and what about exercise on prescription model then, that we use in our country? So, we use a book, it's called the Phys book. It's, you can download it. It's freely available in English, the last version from 2010. It will give you the evidence-based indications for 39 diseases. What kind of physical activity is good for hypertension? What is the mode of action? What is the dosage? Type of activity, intensity, frequency, side effects, contraindications, and similar to the book of pharmaceuticals, right? And this book is not enough. This is the website, by the way, so you can download the English version, 650 pages. The new version is even more evidence-based. But we need a model around it. You cannot have the book. It's not enough because people not use it. So there is a, then we developed the Swedish physical activity and prescription model, this includes 3 elements: individual counseling, individually tailored physical activity recommendation with written prescription, and structured follow-up. And that could be telephone calls, follow-up visits, email, and so on. But it's not to send somebody to training camp, so to speak, for 3 months, or a PT, refer them to a PT to train. Not the idea. The idea is to give them advice, maybe have a coordinator who will help them and translate the prescription, like to go to the pharmacy. You can go to somebody and help you with this prescription, and then go out in the real world and do this in the real world. We can talk about that later. Is it working? This is one of the studies we have performed in the primary care. So there is lots of studies now. There is 3 or 4 theses in our country and lots of studies on this model. So we did a systematic review last year, and this has now been accepted in British Journal of Sports Medicine, so it's soon out. This is the first systematic review on the model. And that was part of the health technology assessment report at Sahlgrenska University Hospital in Gothenburg. So the aim was to see if the Swedish model of PAP was better than not using it for people who were deemed in need of increased physical activity in healthcare. And it was a systematic review of the existing studies. So we identified the relevant articles, going from a process of 1,000 papers down to 9, who were randomized control studies, including 7 randomized control studies, 1 cohort study, and 1 case control study. And if you're looking at the outcome variables, the only variable there were enough papers to really discuss is the level of physical activity, and that's also the main outcome. So there were 5 RCTs and 1 cohort. It's not to say that it doesn't have effect on the other outcome variables, but there was too few studies, and we also know that if you can increase the level of physical activity, that's the goal in itself, because then you know from other thousands of studies that it will have effect on the outcomes. So primary outcome level of physical activity, is it working? And the evidence said from the grading that 3 out of 4, yes. So there is evidence from the systematic review that the Swedish physical activity on prescription increases the level of physical activity compared with no physical activity on prescription. So it does have an effect on the level of physical activity, different measures of physical activity in the different studies, that's the limitation, but all going in the same direction. So we can confidently say that we have a model now that can increase the physical activity in inactive people in healthcare. And I think that's very important. And maybe the key, this is not this is more like a discussion or opinion. We believe that the patient-centered approach is the key to this, that we really individualize the prescription, taking care of discussing other, the motivation of the patient, interest of the patient, but also other diseases and concomitant diseases and pharmaceuticals and so on. So we really individualize the prescription instead of just saying, be a little more active. And we think that's the key. And I also think that in modern medicine, we should, of course, continue controlling for blood pressure, temperature, and heart rate when you go into a hospital, but you should also, on every patient, which has now been decided in my hospital in Gothenburg, Sahlgrenska University Hospital, that every patient should be asked about the lifestyle, so to speak, lifestyle records. That means alcohol, physical activity, and that means diet and smoking. And that should be in the medical records. So to summarize, lifestyle-related disease have increased worldwide, since the 80s at least. and lifestyle behaviors have worsened, and we need all major international societies do recommend it as first-line treatment, but we have to get together. Maybe we can talk about that. We have to get together on a common ground here. And we need to record lifestyle in modern medicine. This is modern medicine because lifestyle is most important for our patients. And we also need methods with scientifically proven effect to increase the activity. And now we have this Swedish physical activity on prescription model to use. Thank you very much.